This conference will now be recorded.
Okay, so welcome to class. So today we are going to do the obstetric SBAs. Okay, so I'll be asking you questions, and just you give try giving answers. Okay, so this is the question number one on the screen. Now you have got 20. Some voice is coming. So like there is a 20-year-old woman with a diagnosis of genital herpes. At what gestational age there's a risk of transmission to the baby is greatest? You can answer.
Is it ma'am D option? No.
Yes,
No.
very nice. So answer is third trimester. So risk of neonatal transmission of HSV is high, that is 41%. Those who acquired primary herpes simplex during third trimester, and they are shedding at the delivery time also. Okay, so very nice. Now, you admit a woman with 40 weeks with a confirmed gestational herpes. This is thought to be a primary infection. She was offered cesarean section, but she refuses. How would you manage the patient?
Just give me some time.
Which option?
Ma'am, is it D option? Commensal or intravenous acyclovir and also offered the neonate intravenous acyclovir?
Yes. Now, if the patient choose for vaginal birth at the time of lesions, that time mother and there is a risk only for the mother and baby. So there would be IV acyclovir to the patient, and this is the dose: 5 milligram per kilogram of body weight per 8 hour, and also it is given to neonate, that is IV 20 milligram per kilogram per hour 8 hourly. So this is these are the doses for mother and the baby, and you can see the maternal dose is less and the baby dose is high. So
Yes.
yeah, you have to kind of remember this, because sometimes they will give you the doses also in the question. Okay, very nice. Now the lactate cesarean section performed on a 30-year-old woman, RN negative, at 37 weeks of gestation. She's receiving cell salvage. What would be the plan regard to HD prophylaxis? If and
Ma'am,
you're not aware of the baby's blood group.
yeah, we should administer 1500 international NTD and then take a sample of maternal blood 30 to 40, 45 minutes after ICUs for fetal-maternal hemorrhage
Very
estimation.
nice. So if the inter-operative cell salvage is used in the cesarean section when the mother is D negative, then minimum dose of 1500 international unit NTD and immunoglobulin in the maternal sample is taken for estimation 30 to 45 minutes. So this is the answer C. So that is fine. And because the blood is getting transmitted, so there is a very high risk of getting fetal cells. Because of that, they are giving such a high dose, and also they are taking the sample. Now recommended dose, and recommended is for 26 HD women who is not sensitized. What is the correct choice?
D.
Yeah, very nice. It is again D. So 1500 international units NTDI immunoglobulins are given at 28 to 30 weeks of pregnancy, or five and second regime is 500 international unit 28 weeks, and 500 international 34 weeks. Very nice. So this is the summary about it. Now coming to, so the patient, 20 weeks patient present with bleeding at 11 weeks of gestation. When you will consider NTD injection to this woman?
If the ma'am bleeding is repetitive and associated with pain, I'm not sure though.
Yes. This is the answer. So, when the bleeding, when there is a recurrent episodes of bleeding, or it is associated with pain. So, like NTD prophylaxis is given 250 international unit, and these are the indications: ectopic pregnancy, molar pregnancy, therapeutic termination of pregnancy, and in some cases of uterine bleeding, which is repeated, heavy, or associated with pain. So, these are the indications less than 12 weeks, and this is the dose. So, this you should remember. You can get any.
Then, ma'am, if the bleeding is heavy but she does not have pain, then we don't need to give it because otherwise, why not B option? I mean, bleeding can be heavy, but if she doesn't have pain, then we don't have to give this, right? It's
Yes, it has to be given when the pain is there or bleeding is recurrently happening. See, if the bleeding is happening again and again, then every episode of bleeding there could be small chance of uterine hemorrhage. So they are giving. And if it is associated with pain, then usually when the contractions are there, there could be
okay.
possibility of some amount of the fetal hemorrhage. So either bleeding is heavy, sorry, if bleeding is repetitive, or the pain is there. So either of these two or both of the two can be there.
Okay, ma'am.
Okay. Only heavy bleeding will not be in the will not be the indication, because if the spontaneous miscarriage occurs, then we don't give NTD, isn't it?
Got it. Got it.
Yes. Now the patient is admitted with undiagnosed breech, what is the best indication for the cephalopropylic CPD is unlikely to happen.
E, ma'am. Simultaneous easy passage of fetal thighs and trunk to the pelvis.
Yes. So if easy passage is there, then we are a bit happy only. And these are the indications where vaginal birth should not happen. You should just, for the summary: hyperextended neck, high weight more than 3.8 kg, less weight less than 10 centile, footling presentation, antenatal compromise. These are the condition like where vaginal birth is not allowed, and these are the independent indications for cesarean section. Now you are called to delivery of a 30-year-old preemie who is pushing. Baby is in the breech position. It is baby head is strapped at a centimeter. What you will do?
Ma'am will give the Darshan incision inside the cervix at 3 and 7 o'clock position.
Yes. So it is not 3 and 7 according to the guideline.
2, 10, 2, 6, and 10. Yeah.
2, 6, and 10. And what they say that the head entrapment can happen in 14% of the vaginal births. Okay.
Mm.
Okay. 30-year-old woman with 35 weeks of gestation. You scheduled external cephalic version. What is the success rate you would like to give to this woman?
At 36 weeks, what is this? Ideally, in primary derivative, we should do at 37 weeks.
Yeah, but you have to give the rate.
46, is it D, 56 to 64? C, okay.
Basically, the book answer is C, but overall success multipara is 60 because of the laxity of the abdomen. So conversion is easy, and nullipara it is 40% because it is all difficult things and tight abdomen, and overall success rate is 50%. So it should be somewhere 50.
Okay.
Answer should be nearing 50. So this is 50, nearing 50 C.
Mm.
So the approximate answer we are giving, yes.
Okay.
So which maneuver used to deliver the arm of the baby?
D, ma'am. Loftus maneuver.
Yes, very nice. So this is the love sex maneuver. You guys can see this very nicely. So the baby is held at uh, the baby, and the baby is rotated 180 degree. So posterior shoulder will become anterior and deliver, and then the similar happens in the another direction. So this is a lobster's maneuver. So tenth teacher at 10th week pregnant, she contacted with chickenpox. When you will say the child is infectious.
Ma'am, 2 days before and 5 days after the rest. That means 2 plus 5. Yeah, 48 hours and 5 days. Last option.
Yes, until basically until it is crusted.
Mm.
Okay, so it is 48 hours before the rash appears, and continue until the vesicle is crusted, and this is within the 5 days. So answer is D, and you can see these are the vesicles of the chicken pox. When they form a black crust, then they are not infectious. The 20-year-old woman from Nigeria, 12 weeks, she has got no chicken pox in the past. What is the advice?
Ma'am, D, to undertake serum screening for varicella zoster immunoglobulin.
Yeah.
Just is it correct? Just let, yeah, yeah, it's
So, to reassure, so answer is D. To take, if she is not sure, so we'll take the serum. When the serum, if she has got immunoglobulin, then we can just kind of reassure her. So this is from the new guideline only. Apart from this, post-exposure prophylaxis can be offered if the serum is negative or if it is less than 100 international unit per ml. Okay. Now, which type of shingles poses greatest risk to the woman?
pregnant. Ma'am, those which are on the exposed areas, D, ophthalmic shingles.
Yes. So herpes disseminated zoster and exposed zoster, like ophthalmic is an exposed one. So because of that, this is a risk of infections. Though herpes zoster is considered to be the infection that doesn't spread. Okay, so Gravida 3 delivered a term baby 3 days before after she developed chickenpox. She was commenced oral acyclovir. How you would manage the baby?
Ma'am, administer varicella zoster immunoglobulin IgG to the baby with or without a oral acyclovir.
Hmm. Yes. So what the guideline says, if the baby is delivered within 7 days of and the mother developed chickenpox, so unit receive prophylaxis as soon as possible with varicella zoster immunoglobulin with or without acyclovir. So you are running antenatal clinic with epilepsy, and you are about to counsel the patient risk of pregnancy and importance of applying medication. What is the strongest risk factor for the sudden death?
Then D, uncontrolled tonic-clonic seizures.
Yes. So tonic-clonic seizures, these type of seizures are associated with highest risk of SUDEP. So what advice you will give 26 years old woman with epilepsy on valproate who attended preconception counseling?
So is it C, change the antiepileptic drug to the lowest effective and least teratogenic AED dose and commence on folic acid at least three
Yes.
months?
Yeah,
C,
so
yeah.
the patient and the family member to be informed that the long-term neurodevelopment effect can be there on the newborn if they are exposed to sodium valproate. So ideally, if the patient when the woman they are want to get pregnant, so valproate, if possible, it should be changed to the another medication. And all of the women who are taking antiepileptics, they should be given 5 milligram 5 milligram folic acid prior to conception, and they has to continue till the first trimester. So answer is C. 26-year-old woman. She has been treated as a case of gastroenteritis. She failed on the treatment. On third day, she rapidly died. Postmortem suggests that she died from sepsis. What is the most common cause of substandard care in the management of sepsis that result in morbidity and mortality?
It is mostly to failure of recognition of the signs of sepsis. D.
Yes. So the people are not able to identify sepsis.
Mm.
Okay, woman died from the sepsis at 30 weeks. What is the most common site of infection associated with septic shock?
Urinary tract, ma'am. Urinary tract.
Yes, it will be the E. coli. This is according to the new guideline only. Organism causing septicemia. This is the E. coli, and this is 37%. And E. coli usually affects the urinary tract. So, 26-year-old woman with a constant pain of 3 days duration. She has abdominal tenderness, no specific localized sign. Blood pressure is fine. She is tachycardic. Uterus irritable. CTG is fine. Urine analysis is negative. She administered painkiller. Pain remains unchanged after 24 hours. What could be the cause?
Ma'am, let give me some time. I just read. Genital tract sepsis, ma'am. I'm not sure though.
See, urine investigations are negative, so infections are not there.
No.
Infection is not there. Total could not be there. Abruption could not be there because CTG is fine.
But
Pyelonephritis.
ma'am, but degenerating uterine fibroids we should have to be able to see the fibroid in ultrasound.
But USG finding is not given.
Yes, ma'am. Then I'll
Uterus is
go with A.
irritable. Only this is the
Okay. A option, degenerative uterine fibroids.
uh,
Is it, ma'am, degenerative uterine fibroids?
irritable uterus. But in degenerated fibroid, there should be localized tenderness. Okay, there is
Hmm.
no specific localized tenderness. If localized tenderness is not there, then uterine fibroid cannot be the answer. Uterine fibroid causes localized problem, localized pain, and like other
But
symptoms.
we cannot take pyelonephritis also because again urine is negative.
Pyelonephritis is not there. Uterine infection, it could be sepsis only then.
Genital tract sepsis, yes, ma'am, should be.
UTI has been ruled out, so it is
Yeah.
not degenerating fibroid because localized problem is not there.
But
There is no
UTI is different and genital tract sepsis is different. So B seems to be the best out of
beast
all.
answer. Beast seems to be the best answer. Yes. So pain for 3 days, abdominal tenderness, and irritable uterus. Irritable uterus, that means endometritis kind of thing is there. Because of that, it is genital sepsis. It is not degenerating fibroids because a fibroid will cause localized tenderness. It is not torsion because torsion will give a toxic look and all the intermittent kind of pain could be there. Placental abruption will cause some changes in CTG and the hypotension
Yes.
finding should be there. So it is not that. Pyelonephritis has been ruled out because urine test is negative. So basically, like mix and match, answer by exclusion only. So nice makes uh, fetal heart. So what are the recommendation nice makes regarding fetal heart?
Not measuring fetal heart rate in labor. Mm, this proposed solution discriminates the- Is it that intermittent auscultation should occur every 10 to 15 minutes?
Intermittent auscultation. No, in first stage of labor they say it is every 30 minute.
Okay.
30 minute for contraction and 15 minute for it is 15 minute for fetal heart. It is not 10 to 15. It is 15 in first stage and 5 minute in second stage.
Okay. To record acceleration and deceleration of heart. I'm not
Yes.
sure. Is it?
Yeah, this is the answer and why it is the answer. Because CTG should be discontinued after 20 minutes. So A is
Hmm.
wrong.
Hmm.
CTG is performed with a woman with indication. So B is wrong.
Yes.
CTG should be continued when it is confirmed to be normal. No, CTG when the patient comes and CTG applied, then
Hmm.
20 minutes they have to do. It cannot be removed immediately. D is wrong because it is 15 minutes, and so left out answer is C. Sorry, E, and this is given. This is from the guideline. Return to intermittent auscultation if CTG monitoring has been started, and CTG is normal after 20 minutes. Okay, and answer is E only. I might have put somewhere else that exactly same line is written in your guideline. Okay, it
Okay.
is there. So this is all about the intermittent auscultation. It is done with the pinard or the handheld Doppler. So intermittent auscultation is carried out after a palpated contraction for at least 1 minute and repeated every 15 minutes. Should be recorded as a single rate on partogram and its note, and record if any acceleration or deceleration is there. Okay. So this is in the first stage of labor. So it is 15 minutes. Okay.
Mhm.
Midwife is admitted alongside unit in your hospital. What be the initial assessment that warrant transfer of a low risk woman to obstetric unit? Now you have to choose the indication for transfer.
I'm not sure if D, rupture of fetal memories 12 hours before the onset of established labor.
Okay, now it is C. So basically, this is too much of a learning. So first A is not there because it is pulse 120 over two occasion, 15 to 30 minutes apart. Single systolic and raised dystolic. It is single reading of 110 and raised reading of 160. So B is also not there. Rupture membrane more than 12-hour onset of established labor. It is fresh bleeding or blood stain like are not rupture of membrane. Okay, single strand of it is thick meconium. It is not single strand. So the left out answer is C. That is this. Okay, it is a hard, but you have to remember only. So you have admitted primary arrived at 41 weeks. Fetal membranes are intact. Pregnancy is uncomplicated. What is the recommendation for measuring fetal heart?
B.
Minimum 30 second. No, it is 1 minute after a contraction.
So in the last one is written record for at least 1 minute, that's why. Ma'am, A, ma'am, A.
Yes,
Hospital.
yes, A is the answer. You have to auscultate the fetal heart at first contact and every time, because at every each assessment when you are doing, because it is uncomplicated pregnancy. Okay, so when the patient comes, these are the observation on the unborn baby. So all this they will do. Auscultate the fetal heart rate minimum 1 minute immediately after contraction. Okay, answer is A. So woman in the alongside midwifery-led care, she has ruptured the membrane at 6 centimeter dilatation. Liker has lumps of meconium. She has been transferred to obstetric unit. What is the precaution?
B. Ensure that availability of healthcare worker trained in advanced neonatal life support at the time of birth.
Yes. So if the meconium is there, then uh, there like what when there is a CTG should monitoring to be done. Apart from this, there should intimation to the neonatal team, and there should be a advanced neonatal support system. So these are the two things. If the CTG monitoring and the neonatal support. Okay, so the patient has got absent fetal movement for 24 hours. What is the best method of diagnosing IUFD?
24. Best method basically. Real time ultrasound with color Doppler.
Yes, it is the real-time ultrasound, and this is a real-time ultrasound uses high frequency sound to create live images of the internal organ and allow real-time observation of movement and flow. So this is real-time ultrasound, and if in the IUFD spalding sign should be there, that is the overriding of the fetal bones and the absent flow. But obviously the flow will be absent. Now 20.
So,
Okay, so 27-year-old women have GBS carrier diagnosed with IUD at 34 weeks, and now you recommend GBS carrier status.
no antibiotics required for this because she has got an IUD baby.
Yes, so there is a no risk of transmission, and so the antibiotic should not be given. Answer is E. So midwife, 30-year-old priming regular 36 weeks of gestation. Uh, we cannot. Her fetal heart cannot be heard in the community. You have seen the patient diagnosed as IUFD. What will be the next step? Now you see a patient and the patient has IUFD. What you will do next?
We'll break the news, but
Yes,
she's alone here, unaccompanied. Right? So
call someone.
first we'll call her a partner or relative or friend.
Yes, if the woman is accompanied, immediate offer an immediate call for partner, family, and friend, because this is the first step for the breaking bad news. So, what will make you classify 26 whole hemophilia career as an obligate?
Ma'am, C option. Her father is affected, or she is an affected son and an affected relative in the maternal line.
Yes. So, woman is an obligate carrier if her father has hemophilia, if she has got affected son, an alternative relative in her maternal line. Okay, so you see a 23-year-old woman, 29-year-old partner has hemophilia A. There is uncertainty of severity to this hemophilia. What is the main difference between severe and mild and moderate forms of hemophilia in terms of clinical manifestation?
Is it D option?
Yes. So males with severe hemophilia, severe hemophilia will have bleeding in the muscles and the joints, and they require regular prophylaxis with a clotting replacement to avoid erythropathy and neurovascular compromise. So D is the answer, because there is a risk of spontaneous bleeding to the muscle and joints. That is severe. Now the patient, 26-year-old woman, has severe hemophilia A. She is now 7 weeks pregnant. What is the advice?
We should offer fetal sexing by free cell fetal DNA. D option.
Yes. So we want to know the sex of the child. So because it is a sex X-linked disease, if male and female has got different management, so fetal sex determination by FFDNA from 9 weeks onwards. 22-year-old woman at 20 weeks, her partner has a severe hemophilia B. Detailed scan is normal. She is informed the baby is male. What should be done?
Then E, reassurance and support during the pregnancy.
Uh,
Because it is an X-linked disorder, so it will not pass from father to son, never. So it should
okay,
be
yes,
reassuring.
yes, you're right. Yeah, so answer should be E. Yes, excellent. So it will, as a partner is affected, so it cannot pass to the baby.
Mm.
So answer is reassurance. Okay, this is just a
30%. 30%.
previous guideline. It was 30%, but the new monochorionic guideline, it is 20%. The percentage has been changed.
So, ma'am, if our exam comes, we need to do 20% this time.
Yes.
Okay. Okay. We have been knowing this
Usually,
as 30% all along this time.
usually in the exam, you have to
Okay.
always give answer from the updated guidelines, and usually you will find a cluster of questions from the updates.
Okay.
So it is well recognized that MCMA have got a high perinatal loss. At what gestation?
It's, it's from before 24 weeks of gestation.
Yes, it is before 24 weeks. Now, which type of anastomosis is common with TTS?
It's a one-sided and from high pressure to low pressure. So C, C.
Yes, so it is unidirectional AV communication. Unidirectional AV communication is the answer. So TTS is most likely to develop in which kind of monochorionic pregnancies?
From 16 weeks. 16 weeks. B.
Yes. Yes, B is the answer. I didn't put the answer, but the answer is 16 weeks. So 20-year-old the woman with 30-year gestation, generalized pruritus. So what is the how common is the complication of pregnancy in UK? What is the incidence basically?
D, 7 to 8 per thousand.
So, according to the new guideline, in UK, ICP affects 0.57% of the pregnancy. So, this is the answer. But if they if they give you that which ethnicity has highest, so it is Indian Asian and Pakistani Asian, and 1.2 to 1.5%, and there would be 25% of the women develop itching in the pregnancy. So, these are some numbers from this guideline. So, a patient presented 31 weeks with generalized pruritus. Itching is worse at night. Stool become paler. She is not jaundiced. You suspect obstetric cholestasis. You request LFT and bile acids. Once they come back normal, what will be the frequency of measurement?
Every week. D.
So, like it is according to the new guideline, this is the table. The question is framed from the previous guideline. So, according to the new guideline, it is 1 to 2 weekly. Okay. So, in your question,
Yeah.
in your in your exam, question will be framed rightly, so that the answer would come from the new guideline.
Okay.
It is recognized that various events in intrapartum reduce risk of operative delivery. So, uh, what is the single most factor that shows to avoid operative delivery in 29-year-old woman?
B, ma'am. Continuous support during labor.
Yes. So, encourage the woman to have a continuous support. So, a 32-year-old woman went to labor in 40 weeks. She has an epidural. She's what is the effect of delayed pushing on 1 to 2 hours on delivery? What will happen? with a delayed pushing.
Hmm. It will decrease the risk of rotational operative interventions.
Yes. So recommend delayed pushing with epidural analgesia as it may reduce the need of rotational and mid pelvic assisted vaginal birth. Okay. The questions usually comes within the lines of guideline. Okay, here I have already put the answer. What increases the risk of failed instrumental birth? So this is the answer: BMI more than 30, short maternal stature, baby weight more than 4 kg, had a circumference more than 95th centile, OP position, and mid pelvic birth or when more than one fifth is palpable per abdomen. Okay, so these are like the FI2 has got a needle stick injury. The patient is HIV positive. What are the risks that HIV trainee will get infection?
0.3%. It is C, 3 per thousand.
So answer is C. It is 0.3%. So the midwife is suturing episiotomy of HIV positive. She has a needle injury. Within what period it is most effective? PP.
Which should be started as early within 1 hour.
Answer is ideally within 2 hours. So here 2 hour is not there. So answer will become A.
Ma'am, may I ask you something? Ma'am,
Yes.
like we are solving the recalls and all. So, what is the
Yes.
percentage of repeated questions can I expect in exam?
See, the scenario has changed. Previously, they used to give lot more recalls, and but now the scenario has changed. You will find the blend of the questions. There would be some repeats, but there would be new questions also, and always it happens. Apart from this, previously number questions were too much percentages, but the last few exams number questions are coming less.
Okay.
Yes.
Ma'am, still, how much can I expect to be the repeat questions?
Yeah, this is very hard for me to say.
Mhm. Okay. Okay, ma'am. You can continue.
Yes. So post-exposure prophylaxis for viral replication can be inhibited following exposure. When mucosal barrier is reached, how long it will take virus to be detected in blood? If the
E, ma'am.
mucosal,
5 days. E.
uh, C, yes, no, no, it is C. I wrote why I wrote C. So antibody test can detect within 90 days. Antigen antibody test can detect 90 days. And net can detect 6 to 8 days. So 6 to 8 days.
Mhm.
So it will become then E only.
Ma'am, how many questions are left?
In this paper 7. So 32-year-old woman complained of breast lump and from her routine visit. Following investigations are confirmed malignancy. What is the impact of breast cancer pregnancy on the prognosis of her cancer?
No, it has no impact on the prognosis.
Yes. There is no impact on the prognosis. So pregnancy itself does not worsen the prognosis of breast cancer. Women with 30 weeks referred by the midwife to consultant led care with a left lump in breast. You examined and found a discrete lump on the left breast with a feature of malignancy. What is the investigation to be offered to this woman?
No, ultrasound scan. E.
Yes. So USG is the first to assess the discrete lump if the cancer is confirmed. Okay. Because mammography will cause radiation. If mammography is necessary, can be used with a fetal shielding, but the investigation of choice and first line will be USG only. So, what advice you will give to the breast cancer who conceives after completing course of tamoxifen, but the metastasis is found on the lungs? So, I already put the answer. To avoid pregnancy because life expectancy is limited and the treatment of metastasis will be compromised. Because if the patient is pregnant, we cannot give her radio and chemo, and metastasis means the disease is spread, so life expectancy is also limited. So, answer is C. 24-year-old woman admitted with 30 weeks of gestation and regular contractions. Now, her pregnancy has been uncomplicated. On examined, cervix is found to be soft. Decision was taken to give steroid and to commence her on tocolytic nifedipine. What is the benefit of nifedipine giving to her?
It prolongs the pregnancy by 2 to 7 days.
Yes. So we give nifedipine because according nifedipine can prolong pregnancy by an average of 18 days, but more successful it can be delayed to 7 days. So according to this scenario, answer becomes E. So a patient has a antenatal care 8 weeks. What is the recommendation with regards to blood group and antibodies?
A, ma'am, test blood group and antibody booking and then at 28 weeks.
Yeah, so at antenatal appointment 8 weeks, offer blood test to check.
Ma'am, no, no, I'll go for B, ma'am. Why should I test blood group at 28 weeks again?
Yes, this is a query all the time. Why the blood group to be repeated? But see, this is a screenshot from the guideline only. At 28 weeks, they are repeating the blood group again. They are doing FBC, blood group, and antibodies. They are repeating it.
Okay.
Though this cannot be answered because FBC is fine because hemodilution will be there. Antibody may appear in the later part of the pregnancy. But why they are repeating blood group? That there is no reason for that, but it is given as like that in the antenatal guideline. So answer has to be this only. Okay, what is a severe
What is it?
postpartum hemorrhage?
2 liter, more than 2 liter.
Yes, so more than 2 liter is a severe hemorrhage. Okay, what is the
Ma'am, can
most?
you, can you, ma'am, can you give the previous slide? Just want to take a screen.
I'll put this on the website. This class.
Okay.
So, what is the most
What is
common
the
cause of PPH that you know already?
atonicity?
Okay. Okay, so thank you for joining. Any question you can ask?
No. Thank you,
Okay,
ma'am.
all the best.